Hello. Today I would like to discuss how we evaluate children born with a cleft who are struggling with their speech, and what my speech team and I can do to help to try to get a child to normal speech. I am James Seaward, a pediatric plastic and cleft surgeon at UT Southwestern Medical Center in Dallas, Texas. In this video, I would like to start with the difference between speech errors caused by resonance and by articulation. Let's go back to looking at the face from the side. If we project our view so we're still looking in the same direction, but now we're looking at the middle of the face, it will look something like this. A resonance error is a type of speech error in which there is an inappropriate amount of air coming out of the mouth or nose for the speech sounds the child is trying to make. For children born with a cleft, this is most commonly, but not always, too much air escaping out of the nose, and this typically needs to be treated with surgery. An articulatory speech error is a type of speech error caused by the child using the wrong position of their lips, tongue, and teeth for the sound they are trying to make. And there are three main reasons why children born with a cleft are more likely to have articulatory errors in their speech. The first is to do with the teeth. Let's consider the F and the V sounds, F and V. We make these sounds by touching our bottom lip to our top teeth to create a thin stream of air. But children born with a cleft often have a missing tooth at the location of the cleft, together with a gap in the bony arch of the upper jaw. This means that they can struggle to make the right size hole in order to make this sound correctly. These errors often improve with bone grafting and orthodontic treatment. The second is to do with the jaw position. Let's consider the T and D sounds, T and D. These sounds are made by the tongue touching the roof of the mouth behind the top teeth, building up pressure behind the tongue and releasing it suddenly. Children born with a cleft may have an upper jaw that grows at a slower rate than the lower jaw and is positioned behind the lower jaw. In this case, they can struggle with moving the tongue so it can reach the roof of the mouth behind the top teeth, and this often improves when orthodontic or orthognathic treatment is complete. The third type of articulation error is learning new ways to make sounds to compensate for another speech error, like a resonance error or the articulations we just discussed. These compensatory errors often need to be addressed using speech therapy. So how do we work out whether the child has a resonance error that will need surgery to improve, an articulation error that will likely improve on its own, an articulation error that needs speech therapy to improve, or a combination of these? Well, at this point, I would like to introduce you to our cleft team speech pathologists. These ladies are experienced in listening to children born with a cleft to determine which type of speech errors a child has. They will typically listen to the child in clinic and take a recording of the speech for the clinical records. Based on what they hear, they will either recommend a program of speech therapy, or if they suspect a resonance problem, they will arrange for speech imaging. This speech imaging consists of two imaging studies. The first is lateral videofluoroscopy. This is an X-ray test in which we look at the palate moving from the side as the child talks. Here you can see a girl looking at some pictures to keep her head still during the study, and the machine that takes the X-ray pictures as she is talking. If we go back to the side view of the middle of the face, which you'll remember, the images we get from fluoroscopy are very similar. You can see the hard palate between the mouth and the nose, and the soft palate behind. If we now look at the soft palate as this child speaks, you will see that it lifts nicely, making good contact with the back of the throat. This is normal movement and is what I aim to achieve. Here are some examples of how this imaging can show problems with this valve system. Here is an example of touch closure, where the soft palate just about reaches the back of the throat, but not with enough force to act as an effective valve. Now an example of a small consistent gap and a larger consistent gap. And finally, an example of a palate that really isn't moving well at all. The information from this study can help to show which type of surgery is most likely to help for the individual child. The other type of speech imaging is video nasendoscopy. In this study, a small camera is placed into the mouth and the nose, and we can see the soft palate moving directly. It gives us images like this. Going back to our familiar midfacial diagram, the camera is about here, and it's looking at this area, which means that on the picture the back of the throat is at the top and the soft palate is at the bottom. If we look as the child speaks, you can see the soft palate lifting against the throat and making good contact. This is a normal movement pattern. And here is an example of a palate that is lifting but not making contact, with a large gap. An example of a palate that is nearly making contact but has a consistent small gap. An example of a palate that is just about touching but doesn't have the force required to create a good valve system. You can see the bubbles as the air forces its way through the valve. This study is very helpful to show differences in palate movement between the right and left sides, and to show the speech mechanism in patients who have had a pharyngeal flap. For me, making a decision about whether a child would benefit from surgery for speech takes a team. The speech therapist evaluation is very important, and the information from the speech imaging, video fluoroscopy, and nasendoscopy shows whether surgery can help and which type of surgery is most likely to help the individual child. In my next video, I will discuss the different types of speech surgery I offer.